Hello everyone, new year, new GINA 2026. This talk is not a full guideline review, it is just basically what changed, why changed, and what you should actually remember session. The biggest theme of this GINA 2026 is basically safer acute asthma management, earlier enrollment of AIR or anti-inflammatory reliever use therapy. They updated some pediatric treatment option. They are focusing on stronger OCS stewardship and they have expanded biological guidance. The GINA, as it get updated yearly from new evidence and it is reviewed by GINA Science Committee. 2026 adds some major acute exacerbation flowcharts, revises some oxygen targets and SABA recommendation, and then track one still remains the preferred choice, that is ICS-Formoterol, AIR or Mart therapy in adults and adolescents because it reduces severe exacerbation and urgent healthcare use compared with the SABA based regimen. Let's start with this diagnosis of asthma in adult, adolescent, and children 6 to 11 years. This figure has been simplified as compared to the last year. The broad process starts with taking history and symptoms and clinical examination. Uh, are they typical of asthma? Because if not, then you have to think about alternative diagnosis. It doesn't mean that you have to do further multiple testing to make it prove that it is asthma. No, you have to think about actually any other history or any other examination which make you suggest that something else should be investigated or not. If the symptoms and history and examination, everything is typical of asthma, then your next question is if you have access to the basic lung function testing, that is spirometry. Uh, and if that is not available, the core second part of the diagnosis is demonstrating the variable expiratory airflow. So you can think of peak flowmetry. If these tests are actually negative, you might consider repeating when the patient is actually having the symptoms, or you can consider for some other additional test. But if not, then you have biomarkers which can be helpful to support your diagnosis of type 2 asthma. But of course, these biomarkers, these can be elevated in other condition also. So of course, the biomarkers, low biomarkers doesn't rule out asthma. So if you are not able to confirm variable expiratory flow, then and other diagnoses are unlikely, then the option is to treat the patient empirically with the inhaled corticosteroids and then review the response quite quickly, maybe between 1 to 3 months, including the lung function also, if you do to know have the symptoms that you have been treating and the lung function, if available, is actually improved or not. Because if not, then that is the window period or the time duration where you have to actually refer the patient for higher level advice. So now comes the question that if the symptoms history examination, they are typically of asthma, so that is like obvious. But what we see that in many countries, any patient who is wheezing or is having cough is assumed to consider having asthma. So on one hand, there is a problem of underdiagnosis, but on the other hand, there is a thing called overdiagnosis. So you have to actually look for these core features which make you strongly think that the patient has asthma. It includes like symptoms varying over time, varying over intensity, rather just being constant all the time. They might worse at night, they might be more on waking, they might be triggered by exercise, laughter, allergens, or cold air, and if they occur or worsen with the viral infection. And absolute classic of asthma is that the patient is running and they may get breathless during running, but when they stop running, the symptoms might get worse. This is very distinctive of asthma because virtually nothing else can do that. So if you have COPD, cardiac failure, vocal cord dysfunction, or just unfit, then as soon as the patient stops running, their symptoms will start improving, but not in case of asthma. So this is one thing, if occurs, it is strongly suggestive of asthma. Whereas on other hand, asthma is less likely if the symptoms are chronic sputum production, shortness of breath associated with dizziness, lightheadedness, peripheral tingling. So these, if the symptoms are associated with chest pain and if there is exercise-induced dyspnea with a noisy inspiration or stridor, or there is localized. So in these countries, we can think of TB, of course, because in our country it has a high prevalence. So GINA 2026 has also introduced four separate charts for primary care and emergency department or acute care for adult adolescent children 6 to 11 years, as well as children less than equal to 5 years. Basic goal is to standardize assessment, treatment, discharge, and follow-up. And why it actually matters, because different settings will have different resources and risks. And they have embedded this mild, moderate, severe, and life-threatening into the flow charts now. I'll show you in the next slide. Also, they have told that children up to 17 years, now you have to use a scoring, which we'll discuss in the future slides. So coming to this is the primary care chart for the adult, adolescents, and children for more than equal to 6 years. This is acute care or emergency department flow charts for the same age group, that is adult, adolescent, and children more than equal to 6 years. So they have embedded mild, moderate, severe, as well as life-threatening, all the things in the single chart. Same is for the children age less than equal to 5 years, the primary care as well as the ED care. Now, coming to the next major change or the awareness which GINA 2026 has created is many of us were actually trained to keep saturation more than 94% and sometimes even 95 to 98% during exacerbation. But now the GINA 2026, what it actually says, it lowers the threshold and it tells you that you give uh, oxygen only and only if it is going below 92%. So you remember the cutoff 92%. For adult, adolescent, and children 6 to 11 years, the target saturation is 92 to 95. And for preschool children, it is more than equal to 92%. So the cutoff 92 you have to remember. And they actually tells you that giving high oxygen may be harmful and it actually provides no benefit in the most asthma attacks. So avoid unnecessary oxygen exposure and update your EDN ward oxygen protocol charts. Now coming to one another scenario, that is patient having anaphylaxis along with the asthma. So what they say, you have to treat the anaphylaxis first, followed by the asthma. So give epinephrine first, followed by the bronchodilator. Don't prioritize the nebulization first. First prioritize the mucosal edema, the anaphylaxis, the inflammation, followed by the bronchospasm. Then the other thing which GINA has recommended is conservative SABA dosing. Because in the earlier protocols, whenever a patient was coming in the emergency department with acute exacerbation, it was advised or it was being done that more aggressive repeated salbutamol administration was done. But now let's learn this vicious cycle. Repeated salbutamol nebulization leads to lactic acidosis. This lactic acidosis leads to hyperventilation. Apart from hyperventilation, it has other side effects also like tachycardia, hypokalemia, and tremors. But this hyperventilation is being mistaken as an asthma exacerbation, leading to further salbutamol nebulization, thus creating a vicious cycle. So they basically try to tell you against the use of inhaled SABA, less as you can, because now the data is coming that the regular use of SABA for even 1 to 2 weeks is associated with the increased airway hyperresponsiveness, reduced bronchodilator effect, increased allergic responses, increased eosinophil also. SABA overuse is being seen with the increased exacerbation and mortality. So what they are now shifting is they are shifting this alone SABA use towards the AIR or anti-inflammatory reliever therapy. Now they also say that for mild exacerbation in primary care or emergency department, GINA 2026, it allows ICS-Formoterol as an alternative reliever because earlier we were giving AIR, this SABA or OCS and oxygen to the patient. But now we can actually give this ICS-Formoterol as an alternative reliever therapy. So this is an important move towards making AIR therapy the default asthma philosophy across all the settings. Then there is a stronger recommendation as discussed for the PRAM score in children. This includes few signs suprasternal retraction, scalene muscle contraction, the air entry in the patient, wheezing, as well as oxygen saturation. And 0, 1, 2, 3 is the scoring. So this scoring is to be used up to 17 years of old children, and it improves reproducibility, objective severity assessment, as well as treatment escalation decisions. Coming to the bronchodilator responsiveness, so in between, ERS gave a statement that more than equal to 10% could also be used. A data set came in 2022, I suppose, which showed that more than 10% of bronchodilator responsiveness can be used for this diagnosis of asthma. But now the GINA 2026 has clarified that it's better to use more than equal to 12% and 200 ml increase the original traditional values when diagnosing asthma, because they actually say this 10% value can actually make many true asthmatics become negative, and there will be risk of underdiagnosis. So now the concern is underdiagnosis, not overdiagnosis, and this will become more in younger males. So the major change in the children, that is 6 to 11 years, is the earlier involvement of anti-inflammatory reliever therapy. And this is based on the trial, is CARE trial. So you should remember the name of the trial. So it actually showed that as needed low dose budesonide formoterol in children 5 to 15 years of age, it actually reduced moderate to severe exacerbation by almost 50% compared with the SABA alone. So GINA 2026 now therefore adds AIR therapy into the early pediatric treatment. So you can't actually say that daily ICS is obsolete in children now. No. So GINA now says that at step 1 and 2, you can use this AIR therapy, but still head-to-head evidence gap for this AIR versus daily ICS still remains. So this is the previous GINA, that track 2 step 1 was SABA reliever, but now they have added that you can use as needed ICS-SABA also, or as needed SABA. So this is one thing which is added in the track 2 of the reliever therapy. This is based on the trial, the Batura study, which around 50 lead to 50% reduction in severe exacerbation when you are using alone SABA reliever. So the preferred adult or adolescent approach is still ICS-Formoterol, AIR, or Mart therapy, because few severe exacerbation, less systemic steroid exposure, less urgent healthcare use, and it is simpler to use one inhaler treatment in almost all the steps. So the Mart therapy, ICS plus Formoterol. So in step 3, you can give very low dose Mart therapy, that is 1 puff OD and 1 puff SOS. So the same can be used as controller as well as reliever. Then low dose Mart, step 4 is 1 puff BD or 1 puff SOS. So take one inhalation of ICS-Formoterol reliever whenever needed, with an option for extra dose if the symptoms are persisting. But then you have to stay within the daily dose limits. And the daily dose limits for adults is around 12, and for children it's. So if pertaining to severe asthma, the key changes which has developed in GINA 2026 is basically triple therapy at step 5, that is addition of LAMA, and especially in children's more than equal to 12 years. We'll discuss it in future slides. Among the biologicals, they have added the two things, anti-IgE biosimilar and Depemokimab also. We'll discuss it in future slides. They have also given few data on choosing between the biologics. So the triple therapy actually expanded for step 3. There is addition of LAMA. It is based on the trial, CALOS and LOGOS trials, the phase 3 trial published in Chest in May 2026 only. And the Lancet gave a trial called as Captain, which was a double-blind RCT phase 3A trial. And the benefit of LAMA add-on remains modest as compared with the biologics. So the triple therapy, which was there in COPD, now it has come in asthma also. Now coming to the biologics. So Depemokimab, it is approved for severe eosinophilic asthma management. It is a longer acting, so the injection is needed actually in every 26 weeks. It is approved for severe eosinophilic asthma in children more than equal to 12 years. And for chronic rhinosinusitis with nasal polyposis, it has been approved with the age cutoff of 18 years. So it actually improves the adherence because the number of injection required will be less. It is convenient for, and also the healthcare utilization compared with the previous more frequent biologics schedules. They have also introduced the first biosimilar anti-IgE, omalizumab IgEC for the severe asthma pathway. It's basically will reduce the biologic cost burden. So they have given this table for the non-asthma indication of the biological therapy, uh, including COPD, CRS with nasal polyposis, hypereosinophilic syndrome, EGPA, wherever they are indicated, they have given all the biological therapy. So earlier, GINA used to specify that how many inhalation you can take in 24 hours, but now the 2026 GINA guidelines tells you that if you are using a reliever beyond a specific threshold, you should go and seek the medical attention immediately. So now the focus actually shifts from how much I can take to why are actually needing so much of reliever. The new drug which is being studied for asthma plus obesity thing. So this is the emerging observational data showing GLP-1 receptor agonist. It may improve asthma outcomes in obese patient, although it is not a recommended treatment yet, but definitely it is a signal toward future obesity asthma targeted therapy. So now there is a stronger focus on the OCS stewardship. So what they actually tell you, they tell you that you optimize inhaled therapy first. You use biologics wherever it is indicated to prevent the OCS exposure. Avoid a maintenance OCS and keep it as a last resort. So you monitor cumulative OCS burden over the time, because now they are having more evidence that using low dose steroids for a longer duration, even repeated use of OCS steroids use, leading to osteoporosis, diabetes, cardiovascular disease, adrenal suppression. This is being happening more repeatedly. So it basically emphasizes now to minimize the OCS exposure wherever you can. This we have already discussed that the emerging observational data which suggests that this GLP-1 receptor agonist may improve asthma outcome in obese patient, but this is not actually a formal asthma treatment recommendation yet. Obesity is a major modifier of asthma control and exacerbation risk. So if you are having a drug which can help you in weight loss along with the improvement in your bronchospasm, so definitely it is one of the good drug for future direction signal, but let's see how much it will affect. Regarding vaccination, the evidence has actually updated. The vaccination remains the same, the influenza, RSV, and COVID-19, but just the data has been more. Okay, now they have specified on the inhaler technique. They says that DPI it's actually suitable for patients age 4 to 6 year or older. Check their inspiratory effort if it is adequate. Loading of the dose, breathing out, stronger breathe in, hold the breath for the 5 seconds. So this 5 second is now they have mentioned. They have also mentioned for PMDI as single breath and breath hold. So the preferred normal method with or without spacer for adult and adolescents. So you have to breathe out first, then you have to actuate. Slowly breathe in and hold the breath for 5 seconds. When you are taking it along with the spacer, you use tidal breathing. So during severe exacerbation as well as for younger children, you can use it with the face mask if patient can't use the mouthpiece, especially in frail elderly patients and the younger children. So you deliver one puff at a time and you have to take 5 to 6 breaths after each puff. Okay, now they have commented upon shaking PMDI before each actuation. So some PMDIs are actually formulated as suspension and some as solution. So in suspension, the shaking thing is actually needed. In solution, even if you don't shake, that is not an issue. But since you can't actually remember which inhalers are available as suspension and which inhalers are available as solution, so they tell you to prophylactically shake each and every inhaler before uh, taking the dose. So what happens in suspension PMDI, drug particles, they are suspended in the propellant and the drug does not completely dissolve. So particles gradually they settle over time due to gravity, and this include most of the inhalers. Examples is your salbutamol inhaler, the albuterol one, the budesonide formoterol inhaler, and the fluticasone salmeterol inhaler. Whereas in the solution PMDIs, the drug is completely dissolved in the propellant and it remains uniformly distributed. So actually there is no sedimentation and includes some of the few new inhalers and especially those including beclomethasone and cyclosinide. So now they say what actually happens, what if you don't shake the suspension inhaler? So, can you imagine a bottle of orange juice with the pulp? So, if you leave it standing for a longer time, the pulp settle down in the at the bottom. Upper portion becomes diluted and the lower portion become concentrated. The same thing happens with the suspension inhalers. So now let's talk of a new suspension inhaler that you have just bought from the market, and the patient opens up this inhaler and forgets to shake it before taking the puff. So the first few puff actually may contain more of propellant and less of drug, resulting in underdosing, and patient may come back to you and say that inhaler is not working. But when this inhaler is about to get finished off, then after repeated use without shaking, now these drug particles which were settled down at the bottom, and now if you are not shaking, so now it will deliver you excess drug concentration. So now there will be overdosing. So you understand, if you are having a new inhaler and you are not shaking it in the initial period, you will get a low dose, but in the later period you will get a overdose. So you will may develop side effects like tremor, tachycardia, palpitation, and hypokalemia. Also, there was a study fascinating which tells you that even a delay of 30 seconds after shaking can alter the delivered dose. What they say that this is the 30-second period time that after which the drug particles they start redistributing rapidly. So the subsequent actuation may actually deliver you either maybe a low dose or maybe a higher dose. It depends upon the formulation characteristic, whether it is a suspension or it is a solution. So remember this thing. Actually, teach your patient that shaking the inhaler is the most important part while taking a inhaler. Again, they have commented on some points on sublingual and subcutaneous immunotherapy. So for adults and adolescents with the asthma who are sensitized to HTM, persisting asthma symptoms, remember the FEV1 has to be more than 70% while prescribing skit or slit to these patients. They have added the, for children, the asthma sensitized to ragweed also. You can give the slit along with the HDM slit, but the HTM slit data is insufficient among the children. It's more there in the adults. So these two slit are actually available now in the GINA, HTM slit and ragweed slit, but the ragweed is mainly for the children. Uh, so that was all about for the GINA 2026 update from my side. Stay tuned for more updates. Thank you.